So I'd like to thank the meeting organisers for the invitation to give this presentation, which is a keynote talk entitled "A Year in Diabetes." And thank you for the introductions. It's a pleasure to be at the meeting today. And these are my disclosures. So clearly, the assessment of any 12 months in diabetes is going to be a personal view, and we only have limited time today. And so I've picked out 4 topics that I think are of interest. Some of these I'll be dealing with in a little bit more detail in subsequent talks during the meetings. So I'll start off with something around diabetes therapies used for weight management and a KEYNOTE trial that was published last year. And then a little bit of about weekly insulin, which is now a reality and which we're anticipating is going to be licensed perhaps in the United States first later this year. Move on to immunotherapies for type 1 diabetes, and then perhaps a little bit of a cheat at the end, but talking about things that are in the pipeline. So giving you a feel for what is about to emerge over the coming weeks or months. So to begin with, around body weight and cardiovascular disease, you'll be well aware that the ADA-ESD consensus now has got a major focus on body weight reduction, with the recommendation, for example, of semaglutide and also dulaglutide and indeed tirzepatide as being agents that have got profound weight-reducing qualities. However, the question mark has remained about whether weight reduction equates to a reduction in major cardiovascular events. This was a publication looking at a nationwide cohort from 2022, querying whether that relationship was as linear as we anticipate, i.e. suggesting that low body weight was also associated with an increase in major cardiovascular events, and perhaps putting some doubt about whether weight reduction is entirely a beneficial outcome. Now, this is on the background of the Look Ahead research study that was published 11 years ago now in 2013, which was looking at the impact of cardiovascular effects of intensive lifestyle intervention. And you can see that this study that was largely performed in the United States initially, if you look at the panels on the right, had a big impact on weight circumference, which are both equivalent, and also glycated hemoglobin. But ultimately, those benefits were lost to a large extent with the weight coming back over 3 to 4 years, the HbA1c rising again over the period of the study, and fitness levels beginning to decline. And the Look Ahead study was eventually halted due to what's called a futility analysis, which showed that there was no evidence of significant benefit in terms of the primary outcome, which was death from cardiovascular causes, non-fatal MI, non-fatal stroke, or hospitalization for angina, or indeed any of these secondary outcomes. You can see the p-values on the right of this slide are all nowhere near approaching the level of significance, and it was felt that the trial could continue endlessly, and that would never be the case. Hence, the need for trials showing that weight reduction itself is of benefit. Now, we've seen weight-reducing agents that are also glucose-lowering agents having positive cardiovascular outcomes, and now one of those, that namely semaglutide, in a high dose of 2.4 milligrams once weekly, was compared with placebo, with the aim of establishing whether there was a reduction in cardiovascular disease. So this was the SELECT study, and there's a primary objective that I've just outlined, and this was established to see whether a weight-reducing agent, in this case semaglutide, versus placebo could actually achieve those benefits. So this was a study that was done in individuals who were overweight or obese. They were aged over 45 years, and they had established cardiovascular risk, and so disease, so their risk was high, but they were not individuals known to have diabetes. So the HbA1c at entry to the study was less than 6.5%, and there was no prior history of diabetes. The study was big. 17,604 were randomized in a one-to-one format to receive weekly semaglutide or placebo, and it was an event-driven trial, meaning that it would cease once there were 1,225 MACE events. MACE stands for major adverse cardiovascular events, and in this study, as in previous diabetes studies, this is focused on cardiovascular death, non-fatal MI, and non-fatal stroke. So this was a study that was actually powered to show that if benefit existed, it would be seen, and sure enough, that was the case. So this is looking at the Kaplan-Meier plot. On the x-axis here is the months since randomization, and on the y-axis is a cumulative instance of this composite primary cardiovascular endpoint, and you can see that the two lines diverge, with the line which represents the semaglutide dosing being lower than that seen with placebo. Here, the hazard ratio was 0.8, meaning there was a 20% reduction in the primary endpoint, and this was significant for superiority of the weight reduction. So a fantastic result, and the first time that we have seen weight reduction, this time using a pharmacological agent equating to cardiovascular benefit. This is now looking at some of the secondary endpoints in the study. This is looking at cumulative incidence of death from cardiovascular causes. And although the lines once again are diverging, the hazard ratio here is reduced by 15%, this was not statistically significant. So the p-value here is 0.065, meaning that subsequent analyses in the study were not assessed according to significance. So this was a hierarchical testing often used in this type of study. But I'm going to show you the slides for these composite endpoints just to show that the lines were indeed diverging. So this is looking at the cumulative incidence, the composite heart failure events. That's on the top left of this slide, and you can see there is a 18% reduction in the hazard ratio here. And then the third confirmatory secondary endpoint was death from any cause. Here there was a 19% reduction in the hazard ratio, which, had it been tested for significance, would have achieved the standard level. One of the big differences, of course, between the Look Ahead study, which I showed you earlier, where the weight reduction was transient, but even with a great deal of input from lifestyle coaches and the like, the weight reduction was not maintained. In this study, once patients were in the study and remained on medication, then they did indeed continue to maintain that weight reduction. So you can see here the mean change in body weight for those on active therapy was around 10 kilos, and it remained throughout the length of the study. So the change in body weight was phenomenal, substantial, and it was maintained throughout. What about adverse events? Well, this is looking at serious adverse events in the SELECT study, and you can see that these are much the same. Any adverse event, certainly no increase in those taking semaglutide, and then if you split that up into cardiac disorders, infections, nervous system, etc., there was no significant adverse event profile. Not surprisingly, patients on semaglutide, being a GLP-1 receptor agonist, had more issues around gastrointestinal side effects, but overall, in terms of serious adverse events, there was no downside to this therapy. So I think this is a really important therapy. I'll be talking about weight loss therapies relating to diabetes, glucose lowering during the course of the conference, and I'll give you a lot more detail about that. But clearly you can anticipate there's going to be a lot of additional trials along these lines using new therapeutic agents going forwards. Now on to once weekly long-acting insulin, and we are now very close to the point of seeing the first of these available on the market, and in this case it's insulin icodec, which has been developed and manufactured by the company Novo Nordisk. You can see on the left here a cartoon of the molecule, and on the right, an example of the steady state pharmacodynamic profile in comparison in this study to insulin glargine daily, U100 glargine given on a daily basis. Now, the mechanism by which this insulin has a protracted outcome of glucose lowering is one that will be familiar to many people, in that it tightly binds to albumin, not only at the injection site, but also in the circulation and tissues throughout the body. And this is a mechanism of prolongation that's been used by Novo Nordisk for their GLP-1 receptor agonists, both Victoza or liraglutide and semaglutide. And the trial program has been, as you would expect, fairly extensive. So this is looking at the icodec trial, phase 3 clinical trial program that's known as Onwards. And you can see there have been 6 major studies. In the top row of studies here, these are people who are insulin naive, so they have never been exposed to insulin before, and the top ones are all in people with type 2 diabetes. We had the opportunity to be involved in the Onwards 1 study, which with its extension period is the longest study at 78 weeks with this agent. And then below, in the second line down, you've got people who are already receiving insulin, and these were the Onwards 2 and the Onwards 4 trials in people with type 2 diabetes. Onwards 2 was a basal insulin study. The Onwards 4 was a basal bolus insulin study. And then finally, another study that we were involved in was in type 1 diabetes, and this was the Onwards 6 trial. And the top line data for all of these studies are now available, as are the publications. So let's have a look at the top line studies results. So I guess the most important thing for most people looking at diabetes glucose lowering therapies is change in HbA1c. And you can see that generally speaking, the reduction in HbA1c with icodec was at least as good and generally better than that seen with the comparator. And the comparators here being insulin glargine, insulin degludec, various basal insulins throughout. So generally, at least as good and generally better. And some of these differences were actually statistically significant, albeit probably not clinically significant. Now, the other major element here is hypoglycemia rates. You can see those at the bottom row of these panels, and the hypoglycemia rates in the studies were generally extremely low, and there was no significant evidence of increased hypoglycemia for the once weekly insulin. I'll point you to the 2 panels on your bottom right. This is the Onwards 4. This was the type 2 diabetes basal bolus switch study, and you can see that hypoglycemia rates in people with type 2 diabetes on 4 injections per day were indeed higher than seen in the basal group, but no statistical difference between the two. But if you then move to Onwards 6, you can see that hypoglycemia rates are actually higher in those people treated with the weekly insulin. And this, I guess, will raise issues about whether for certain people who wish to get very tight control of their diabetes with frequent adjustment of doses, whether a weekly insulin really is sufficiently fine-tuned to allow that to happen. On the other hand, I'm sure there'll be lots of people with type 1 diabetes whose control is much less aggressive, in whom a once weekly insulin may well be of benefit. We're very keen these days, as is everyone, on continuous glucose monitoring, and so this was performed in some of the trials. So these are data from the Onwards 1 trial. This is on the panel on the left is looking at the weeks 48 to 52, which was the primary endpoint of the study, and then on the right is looking at the end of the extensions series. You can see that the time in range was high in both the icodec and the glargine treated patients, actually significantly better in those receiving once weekly icodec, and that was maintained with the additional study extension. And you can also see here that the levels of severe and non-severe hypoglycemia were extremely low for both the weekly insulin and the daily insulin in this trial. In terms of patient satisfaction, not surprisingly, people were more enthusiastic about a weekly injection rather than a daily injection. So this is the Diabetes Treatment Satisfaction Questionnaire showing a significantly greater improvement over the stage of the Onwards 2 study at week 26 for icodec weekly insulin than is seen with once daily degludec, and the treatment satisfaction score, as I'm sure many are aware, is looking at convenience, flexibility, satisfaction, willingness to recommend treatment, which were generally enhanced by the once weekly insulin. So we haven't got it yet, but we are anticipating launch, as I said earlier, probably in the United States first. Later this year in the UK, we anticipate we may see once weekly insulin at some point in 2025, so coming soon. How do you initiate? Well, the general recommendation and general use of insulin, basal insulins in clinical trials suggests 10 units per day. And since this is a weekly injection, then it's 7 times that amount. So the recommendation would be 70 units per week. And that's what was done in the clinical trials that I've shown you. If you've got people are changing from existing insulin use, then essentially you're having to multiply whatever dose they're on by 7. Here, there's a presumption that they're actually taking the insulin, and that's something that would need clinical acumen to determine. And then for those with type 1 diabetes or those with poor control, there's a suggestion of a add-on dosing of insulin at the start to cope with the fact that the insulin is going to take some time to reach steady state. So these are the recommendations. Note that the insulin itself is U700 as opposed to U100, and I'm sure that's going to cause some element of concern amongst our pharmacy colleagues when we're seeing this introduced. So these are all going to be challenges for the early introduction of this new insulin product. Now to immunotherapy. This is a headline from towards the end of last year, talking about game-changing immunotherapy. And this is teplizumab, which is now licensed in the United States as a drug that can delay the onset of type 1 diabetes in those at high risk. And this dates back to the trial that was published now 5 years ago in 2019, looking at teplizumab in relatives of people with type 1 diabetes who were at particular high risk due to positive antibody formation. And the risk delay was seen to be significant, and as I said, has now led to a license. Now, there was further trial evidence looking at teplizumab this year that I'll tell you about in a moment, but just to highlight that this has led to the classification of type 1 diabetes moving on from, well, certainly when I was training, where it was you either had it or you didn't. Now, people who require exogenous insulin for type 1 diabetes are labelled as stage 3, or indeed with long-standing type 1 diabetes, stage 4 diabetes. But we've now got these earlier stages that are classified according to antibodies. And I'll be talking a little bit more about this in the classification talk. But basically, for individuals who have got antibodies, specifically more than 2 islet antibodies, but with normal glucose tolerance, these are classified as being stage 1 diabetes, and those with more than 2 antibodies who have an element of dysglycemia, typically on a glucose tolerance test, would be categorized as stage 2. And these stages are now becoming more important in terms of clinical trials looking at newer immunotherapies. And this is largely being brought about by the benefits seen with teplizumab. However, teplizumab has now been looked at in newly diagnosed individuals with type 1 diabetes, and this is known as the PROTECT study, and this was published during 2023 in the New England Journal of Medicine. And perhaps this study is not quite as positive as that seen in the individuals at risk. So here you can see the outcomes on the panel on your left, and this is following two 12-day courses of teplizumab in people with newly diagnosed type 1 diabetes, and you can see that generally things are going in the right way. So the C-peptide preservation at 78 weeks is better in the teplizumab patients. If you look at glucose levels in target range, that's higher in those who received teplizumab, and if you look at the daily insulin dose, then the placebo group were having more insulin than was the case with teplizumab. However, the differences between the groups were not confirmed to be significant for the secondary endpoints, and so this study is not seen as a major game changer for people with type 1 diabetes. However, a different study known from the CLEVER study group examining the impact of verapamil on beta cell function in children with newly diagnosed type 1 diabetes did show a significant benefit, and this was published in JAMA about 12 months ago now. So verapamil is a drug that we had known for many years as being an antiarrhythmic and indeed an antihypertensive agent, but this also has been found to have an impact on beta cell function previously and preservation of beta cell activity. And in relatively small numbers, this study has shown here that there is a benefit in terms of C-peptide. So this is looking at the area under the curve for 52-week C-peptide levels and showing that generally speaking, those individuals with verapamil did better than placebo. And then this is a whisker plot looking at, on the right-hand side, looking at peak C-peptide level at various points during the study and showing that generally speaking, the verapamil group did best. Now, there is a study known as the Vera T1D study that is going on in Europe at the moment, and this is looking at verapamil versus placebo in adults with type 1 diabetes. This study was not halted on the basis of the pediatric study, but there is great interest in how that will turn out. And again, we've been fortunate enough to be a participating site in this study. But going forwards, what I think this may well lead to is a new generation of type 1 diabetes trials where there is a lot more clever design of the studies going on. So the INODIA group, which is a type 1 diabetes consortium, have suggested, and this goes back a number of years now, that there should be a master protocol where to an extent you're adding to existing knowledge as you go through. So the suggestion here would be that from now on we'd be looking at verapamil plus studies, meaning that individuals would go into the trials and automatically receive something that appears to have benefit, and then other immunotherapies would be added to these, and the trials will try and be smarter and shorter and quicker to try and move this field forward, because there's lots of immunotherapies out there that have been used for other autoimmune conditions such as rheumatoid arthritis, Crohn's disease, inflammatory bowel diseases, etc., that have never been tried in type 1 because insulin was seen as the panacea treatment. So perhaps we're going to move forward in what's known as an adaptive trial culture to try and get quicker bangs for the buck. Finally, then, what's coming through the pipeline? Well, there are two trials, cardiovascular trials ongoing at the moment. One looking at semaglutide, that's a SOUL study. The other looking at tirzepatide, that's the dual agonist. These cardiovascular outcome trials, strangely, were both due to finish on the same day in July of this year. It's looking increasingly like they're going to continue beyond that. I understand that the number of events in the SURPASS CVOT study is less than anticipated, and so that study, which is a active comparison with dulaglutide, will be later in coming out, and the SOUL trial with oral semaglutide, we're still waiting for the moment when the trial is put on hold and ceased. So we haven't quite got the cardiovascular outcomes with these two drugs, but we look like we're going to get some positive knowledge about semaglutide This is 1 milligram weekly semaglutide in terms of kidney outcomes. So this is a trial known as FLOW. There was an announcement in October 2023 to say that the decision has been taken to stop this study, looking specifically at CKD outcomes in type 2 diabetes, and the trial is now being completely wound up, and we're expecting announcements regarding this later in the year. So having over the last few years got the benefits of SGLT2 inhibitors now nailed home and indeed fully adopted into guidelines, I think we're going to get something similar for a GLP-1 receptor agonist. And then, of course, the issues or the massive progress regarding dual and triple agonists. So tirzepatide, I've just mentioned, is a dual GLP-1 receptor GIP agonist, but we have alternatives coming through. At the top here, you'll see a glucagon agonist combined with a GLP-1. So this is a new alternative dual agonist that is being trialed in various elements at the moment, but including not only type 2 diabetes, but also as a weight management agent. In the middle here, you can see CagriSema. This is a combination of an human amylin agonist with semaglutide in a dual chamber injectable pen device. This has been trialed not only in type 2 diabetes, but also as a weight reducing agent in those people without type 2 diabetes. So another of these products coming through. And then at the bottom, retatrutide is a drug that is actually a triple agonist. So not only does it have GIP and GLP-1 agonism, but also glucagon agonism. And the emergence of glucagon as a therapeutic target, or the glucagon receptor as a therapeutic target, is particularly interesting because here the weight reduction appears to be due to an increase in energy expenditure. And in the past, increasing energy expenditure has been something that has not been totally without risk. So a different mechanism to that seen with semaglutide and indeed tirzepatide, which will require and indeed is being exposed to full assessment with cardiovascular outcome trials that are now either ongoing or about to commence. So with that, I shall stop my personal review of the Year in Diabetes 2023, and I'd like to thank you for your attention and once again thank the meeting organisers for the invitation to talk.